Hello, everyone, and welcome to the Michigan PolicyCast. First and foremost, we owe you all an apology. We have not recorded in a while. We've been really busy with school and work, and we're excited to tell you about some of the things we've been up to. But the next two episodes are going to be in-depth interviews, and the first one is going to be with Marianne Udow-Phillips, the Executive Director of the Center for Healthcare Research and Transformation at the University of Michigan. She's done a lot of really amazing work over the years, some of it in the private sector, but her most notable credential was as the director of the Department of Health and Human Services under Jennifer Granholm's administration here in the state of Michigan from the years 2004 to 2007. We're so grateful to have access to such a leading policymaker, but we do have to disclose one really important thing from the get-go. The date of this recording is from October 11th, 2017. When we release this, it's going to be a few months later, and there has been one really major policy development since then. As part of the Tax Cuts and Jobs Act, or the TCJA, the individual mandate was repealed, which will exacerbate a lot of the effects around adverse selection. And we're going to go into some of those issues, but ultimately, and this is what's most important, repealing the individual mandate will cause 13 million fewer people to be insured by 2027 compared with the current law, according to the nonpartisan Congressional Budget Office. So that's a really important takeaway, and we're going to get into that among so many other issues in an exploration about healthcare policy in the United States, diving into issues from single payer to ballooning administrative costs, and whether or not healthcare is socialized medicine, and we're going to do some international comparisons and talk about best practices as well. So we're really excited to be giving you this content. And yeah, we hope you enjoy.
Excellent. So welcome, Marianne. Thank you so much for taking the time to talk with us today about the Affordable Care Act.
Yeah, happy to do it.
Excellent. So our first question is just, what was the state of healthcare before the Affordable Care Act was passed?
Oh, excellent question. And, people tend to forget what healthcare was like before the Affordable Care Act was passed and, why we have this law. In effect. And so, what I would say before the Affordable Care Act was passed, if you had insurance provided by an employer or you had Medicare, you had reasonably good coverage, reasonably good access to care. We were seeing people begin to have higher copays and deductibles, so already we were beginning to see people assuming more of the cost of their care. But for the most part, most people in the country had reasonably good health insurance. The people who didn't were the people who didn't get coverage through an employer or were not eligible for Medicare. And those people had a really difficult time getting coverage. So who are those people? They were people who bought coverage for themselves through the individual market, either because their employer didn't provide health insurance coverage, and that's a lot of people who work for very small employers, which are really actually big employers in this country, didn't provide health insurance, or there were people who were not connected to the workforce. So it's really kind of incremental in that it builds on those systems.
Mm-hmm. Yeah, so I remember this debate of sort of the difference in treating Medicaid almost more as a Medicare-like program post-Affordable Care Act versus before. Could you explain a bit about what people talk about when they say, this really, the change in mentality of, the worthy of Medicaid, and now is sort of expanding it to being more broad?
Yes, right, that's right. So, Medicare and Medicaid come from their eligibility criteria, their entitlement programs, which nobody likes the word entitlement, but that is what they are. Medicaid was built off the old poor laws in this country, which were more about certain people got help, not everybody in a certain category got help. So when Medicaid was first passed in 1965, it had a pretty limited scope. It was designed to help those who were old-aged, blind, or disabled. Over time, through various acts that were passed in Congress, it expanded to include children who were in foster care, mothers who were single mothers, and later single parents of children with certain income. So you had to be very poor, but you had to be more than very poor. And so a lot of people, predominantly single adults, who were very poor, were left out entirely. And so Medicaid, the framers of the Affordable Care Act really did want to change that philosophy.
Yeah.
They really wanted to say Medicaid should be a program that is about being poor and independent of other factors in your life. And so that's why it came in and said anybody, or the idea was anybody who's under 138% of poverty should be eligible. Of course, that didn't pan out the way the framers intended,
Right.
because of the lawsuits.
Right. And was it also the case that it was sort of left to the states to decide whether to adopt this provision?
It was left to the states because of the Supreme Court decision.
Okay,
Right?
yeah.
So the framers put a very harsh penalty into any state that didn't expand Medicaid.
Mhm.
They designed it so that the state would lose the entire Medicaid funding that they had.
And
Okay.
could we rewind a little bit to talk about what the Medicaid expansion is exactly? Like,
Yeah.
was the cap expanded, or can you help us understand exactly what that means?
Yeah, so two things really happened with the Medicaid expansion. One is to enable more people to be covered based upon simply income. So anybody who it was technically up to 133% of poverty, but there's a 5% income disregard. So anybody technically up to 138% of poverty would have been eligible for Medicaid. The other thing that the Medicaid expansion did was change how the federal government compensated states.
Mhm.
So the Medicaid program, the other thing that's different about Medicaid compared to Medicare is that it's a state-federal partnership, right?
Mhm.
And when Medicaid was first established in 1965, the provision, the way it was established, is that the amount that the federal government would contribute had to do with basically the income of the state, the financial condition of a state. So it's variable, right? It's anywhere from 50%, 55% to about 75% is a federal contribution. So the poorest states get more, and the better off states get somewhat less. So it's a variable, but in any case, it had a reasonable state contribution that's required. With the Medicaid expansion, just for that added population of people that were not previously covered or previously eligible to be covered under Medicaid, the federal government, under the Affordable Care Act, paid 100% of their cost for 3 fiscal years. But because it became optional for the states, there are still 19 states that did not expand.
Right.
And ironically, they are the states that have among the highest rates of uninsured in the country,
Yeah.
and the lowest and very many low-income people in
So
their states.
these states were able to reject expanding their Medicaid that was required by the Affordable, or not required, but sort
But
of
was
built into the
right.
intended by the
Right.
Affordable Care
It was
Act.
intended to be required, but it turned out not to be required.
Right.
But they rejected this big carrot that was provided by the federal government, and for a variety of reasons,
Yeah.
and have not expanded yet.
Yeah, and can you talk a little bit about the level at which subsidies are available? So what the income thresholds are through which you can receive a subsidy.
Right.
And do you also? I'd love to get a sense of like what proportion of the population qualifies for those subsidies.
Right. So the subsidies, because of the way the Affordable Care Act was structured, the subsidies come in after that 138% of poverty,
Right.
up to 400% of poverty.
Right.
It's a little bit of a complicated formula, so not everybody at the higher end gets subsidies. It depends on actually the cost of the premiums in the state. But that was the basic idea.
Right.
And of those that are buying coverage on the individual market, about 85% are getting tax credits or getting subsidies right now. And so the vast majority, we need to remember the individual market is still pretty small
Yeah.
in this country. So it's 5% of the total market
Wow.
of health insurance are get their coverage by purchasing it themselves.
Okay.
But
And-
these are often people who need it the most.
Yeah.
So does that mean that the other 95% receive it through their employer?
Not
No.
95%. It's about just short of, it's in the 50s that get it through employer-sponsored coverage right now. Huge percentage get public-sponsored coverage right now. So, for example, in the state of Michigan, because we expanded Medicaid, 25% of our state's population now gets Medicaid coverage.
Wow.
Right? And
Right.
so, and another 15% get Medicare. So we're almost at 40% of the population that's getting public coverage these days.
Right.
And then another big chunk that's getting private coverage. And we still have 9% of the country who are uninsured, right? So there's still quite a few people that are uninsured, and unfortunately, I think that number is going to go up because of some of the damage that's being done to the Affordable Care Act.
Right. So one of the things I'm most interested in is understanding what the impacts of a repeal will be. So can you talk about like how, to what extent, who stands, how, the broad question that I'm most fascinated in is what percentage of Americans will pay more as a result of the Affordable Care Act getting repealed? Is that an easy question to answer?
No, because you have to look at the details behind the repeal bills. First of all, it's a misnomer. So all the bills that have been proposed in Congress right now, it's a misnomer to call those repeal bills because they do far more than repeal the Affordable Care Act. If they were simply straight out repeal of the Affordable Care Act, then basically the people who are most vulnerable are the people who got individual coverage. Again, 85% of people who are getting tax credits, that would go away, right? So, that 5% of the population that's getting their coverage in the individual market, a big chunk of people would pay more if they could afford health insurance. Actually, I think most of them would not even be able to afford it at all.
Right.
And then that population who are in poverty, and 3/4 of those who are getting coverage through the Medicaid expansion are under 100% of poverty. They're not even in this category of between 100 and 138. So they probably couldn't afford coverage at all. And that's, millions of people across the country have gotten coverage through the Affordable Care Act and would have to pay more. Who would pay less? Healthy people and young people would pay less because of provisions in the Affordable Care Act that were designed to make the risk pool more affordable for people most in need. It did raise the cost for some people. It raised the cost for younger people, and it raised the cost for healthier people. Yeah,
well, so one of the kind of related questions there, like when we talk about healthy people, like related to pre-existing conditions, I mean, one of the things I've been most fascinated about, like when I've been reading about healthcare, is how many things qualify as a pre-existing condition, like how expansive that category is. And so part of the Affordable Care Act's protections is that insurance companies aren't allowed to discriminate or charge different prices based on pre-existing conditions.
Correct.
So can you help me understand, like what the impacts of repealing that will be?
Right. So if that provision went away, we'd be back in the situation we were in prior to the Affordable Care Act coming into being, and we would have many people who are very sick who, if they could get coverage, would be paying substantially more to the point where it's unaffordable and they become effectively uninsured.
And just to give us a sense of some of the scale, like I was looking at a Center for American Progress study that tried to estimate the annual premium increase for different types of pre-existing conditions, and the numbers I saw were something like, if you have asthma, annual premium increase would be in the range of $4,800. Somebody with metastatic cancer, they would see an annual premium increase in the neighborhood of over $140,000. Do those how accurate do those numbers be? Like I'm just trying to get a sense of like what the financial impact to Americans will be with these pre-existing conditions.
So it's really hard to do those kinds of estimates, and they're making a lot of assumptions behind them because we don't know what the environment would be like post. And again, you have to really look at the details of any law and any change because some of them are because they're very complicated, and so you could have all sorts of different effects. Could people see a 50-100% increase if they're sick? Absolutely. I think the more likely thing is they just would not be able to pay for it. They wouldn't be able to afford coverage at all. And what we saw before the Affordable Care Act were some states that had high-risk pools, and those high risk, which was in a lot of the proposals to repeal the Affordable Care Act, they would put back these high risk pools in the states, but those high risk pools were chronically underfunded, and there was a long waiting list of people to get in. So I think that the problem is that most estimates are that a minimum of a third of people in the country have what would be considered a pre-existing condition.
Wow. A third of people.
A third of the people in the country, and that they would find it very difficult to get coverage at all for the condition that they have, and if they could find it, it could be 50-100% more than they're paying now.
Right. And so for people who get their coverage through their employer, if they have a pre-existing condition, if the Affordable Care Act gets repealed, will those employers be paying more as well? Will the individuals be paying more? I'm curious about that interplay because working with that population who like get their healthcare from their employer, like I think that the urgency or like the consequences of the Affordable Care Act's repeal are less urgent to them because
Yes.
they perceive getting it through their employer. So yeah, what are the impacts to people who get their insurance?
Right. So most employers do not have outright exclusions based upon medical need for people that they cover because they are a group plan, right? So the whole idea around coverage is to have a robust enough group of people, some whom are healthy and some
Right.
who are not, so that you're spreading the cost, right? So that it makes the cost lower for everybody. So there are very few employers that actually exclude particular conditions or people. They may have a 6-month waiting period, and that's in part to discourage people from becoming employed, getting health insurance coverage, and then quitting.
Right.
Just to get the benefit, right? So there's some
Right.
actuarial reasons for putting waiting periods in place.
Sure.
So they might have a waiting period for pre-existing conditions, but very few completely exclude people based upon their health status. So that piece of it will have less effect on the employer market. What would have an effect, however, on the employer market in some of the repeal bills are other provisions in the Affordable Care Act. So some of the provisions, for example, that are very important in the employer market and the Affordable Care Act were the prohibition on annual limits on health insurance coverage and lifetime limits on health insurance coverage. So before the ACA, many employers said, we'll provide health insurance coverage for you, but we won't pay more than $5 million for you for your lifetime. Now, that could sound like a lot of money, but if you have hemophilia, you can run through that lifetime limit in a couple of years.
Mm-hmm.
You have very big needs, right? And so those kinds of limits have been prohibited by the ACA, and some of the repeal bills would have allowed employers to put those limits back in. So that would mean that you'd have, as in the employer market, you'd have
Yeah.
health insurance coverage, but it would be very limited if you were sick and you really needed it.
And I mean, I think that one of the hearing that number, like $5 million for the costs of covering a hemophilia patient, or like covering their expenses throughout their lifetime, it's really stark. And like I think something does that $5 million reflect the cost of actually providing that coverage? Like, what is the cost to like the hospital and insurance provider for that?
That's a very long and complicated question.
Yeah.
The $5 million limit is on what the health plan would pay
Right.
for your care,
Right.
which may or may not was related to cost, but it does not necessarily reflect the actual cost of your care.
Right.
And cost is a very complicated question when it comes to health care and how we calculate what the cost of health care is. But essentially, if you have coverage through an employer, you're almost certainly getting your coverage through a health plan that has negotiated a rate of payment to a doctor or a hospital that is less than what you would pay if you had no health insurance coverage, because you're paying charges, and that's higher than the negotiated rate that a health plan would have. So cost to you is a little bit different than cost to what the health plan is.
I guess, yeah, the cost that I was curious about is how much does the hospital actually pay? Like, how much does the healthcare and all of the, related companies involved, like, does it cost them $5 million to provide the hemophiliac that level of care?
So
Because I'm skeptical of that, yeah.
Yeah, so again, we sort of have to talk about what cost means and
Right.
how that can count. What the $5 million is simply what is paid on your behalf by the health plan.
Right.
What it costs to the hospital, it depends on the hospital, it depends on the pharmaceutical. A lot of that cost for hemophiliac is in the clotting factor itself. So is there profit in healthcare? Absolutely. There are huge profits in the pharmaceutical industry in particular. There are profits for many hospitals, but not all, but they're thin. Most hospitals are happy if they have a 2 or 3% margin, and they need that margin to invest in capital and physical plant and redo their hospital, et cetera.
So some of the, and you're much better informed about this, but like some of the reporting I've read out of like Stephen Brill, like the bitter pill piece, and I'd love to pick your brain. Like I've heard markups in the range of aspirin getting billed at $56 when you could pick up a bottle for like a bottle of 100 for like considerably less. Like I've heard markups that hospitals charge in the neighborhood of like 10,000%.
Right.
And so I know that like hospital CEOs definitely, you know, can make in the neighborhood of like 7 figures, 8 figures. Like, can you speak to those costs?
So let me talk a little bit about Stephen Brill.
Sure.
His articles and what he's talking about in those articles. So he is talking about charges, and this is why I say it's a really long and complicated conversation to talk about how hospitals, doctors, pharmaceutical manufacturers, pharmacies get paid for services, right? They're all sort of different negotiations. But he is specifically talking about the charge master.
Yes.
And it's what if you had no insurance, or sometimes when you get an explanation of benefit from your health plan, you'll see on there the charge was X, we paid Y, you know, and it's vastly different. Charges are a little bit artificial. They're really quite artificial.
Yeah.
And they go back a long way in terms of how we used to pay for health care. And most health plans require that, for a variety of reasons that are probably too complicated and too detailed for us to go into on the podcast, but they require that hospitals have uniform charges regardless of the type of coverage you have. So you have to have the same charge to Blue Cross, to Medicare, to Medicaid, and to somebody who pays for themselves, right? And so hospitals in the past got paid from some insurers based upon the charge, right? They would pay, or a percentage of the charge. They'd pay, 90% of what was on the bill. That's a very old payment mechanism that goes back to the 1970s. Then there was a move away from paying on that basis to paying based upon a negotiated rate, or based upon a diagnosis, or based upon different methodologies that are used now by health plans, Medicare, Medicaid, and others. But the charge structure that goes back to the 1970s was kind of left in place.
Right.
It's not really used by health plans, Medicare, or Medicaid for much, but it was sort of still left out there.
Right.
So when you get a bill as a consumer, you'll see that charge. And the problem with the aspirin issue is it's twofold. It's one about how the hospital allocates its total cost.
Sure.
To tell you the truth, I think there are very few hospitals that actually know what a aspirin pill costs them. They don't do that level of cost allocation to that level of detail. They just spread their costs over the total care that they deliver, and so you get these really artificially inflated numbers. Stephen Brill's point was that if you are a person who's uninsured, you're going to get this crazy bill, and the health plans are out there negotiating prices that are half that. And so why should you pay more as somebody who's uninsured? And he's absolutely right. The whole charge master thing is an artifact of years past in the way we designed hospital reimbursement policy.
And so ultimately there are a proportion of individuals though that are, they do receive these bills and see like $56 for ibuprofen, and that is on those consumers because they don't have the same leverage as like these larger institutions to negotiate.
That's right. Now I will say that after Stephen Brill's article and many others, there were states that passed laws that said you can't charge people who are uninsured more than you charge, or some percentage more than you charge health plans. And so they limited some of that. But still, there are people out there who absolutely get those bills, and they are sent, if they don't have insurance, they're sent to the collection agency to pay. That's a problem.
And so when you were describing hospitals' profit margins being in the neighborhood of 2 to 3%, that's after they pay all their employees, like including their CEOs who make like 7-8 figures, right?
Yeah.
Right.
Yeah.
Okay. I think.
But there are some hospitals who are losing money because, again, we have a very complicated reimbursement system.
Yeah.
It's a long discussion about that. But basically, Medicaid pays less than the actual cost of care. Medicare pays about what it actually costs to deliver care, and private insurance pays somewhat more. And so, if you're a hospital, you have to have some margin because you have to invest in your equipment and new technology, and you have to invest in your, when your hospital starts falling down and you need to replace things, right? So you have to have some savings there.
Right.
So that's what the margins are all about.
Right.
And, the CEO salary issue, they do get paid a lot in the big picture of healthcare. It's not a huge contributor, but administrative cost in the American healthcare system versus other healthcare systems is huge. We have a very complicated system of financing healthcare in this country. much more complicated than any other country in the world, and it adds a lot of unnecessary cost to the system. That is certainly true.
Mm-hmm. And this question is much more philosophical, but
Yeah.
sort of from a very high level, sort of how has like the U.S.'s approach to healthcare,
Yeah.
with regards to it, whether it's a social good
Yeah.
or a good that's exchanged in the marketplace,
Yeah.
sort of that dichotomy, how has that influenced sort of the broader conversations about healthcare?
Yeah, so that is a huge question, and I think we've never really grappled with that question very well. I don't
Yeah.
think we actually have articulated that question. That is a question that's been very well understood in Europe,
Mhm.
and every other developed country in the world has a very clear vision of how they view healthcare. We are very conflicted on whether we believe in the market system.
Yeah.
We generally believe in the market system when it comes to everybody else, but not for ourselves,
Mhm.
right?
Right.
And so it's very much influencing this debate, repeal and replace debate, in a way that's not been explicit, and I think is really problematic because
Mhm.
nobody is talking about what their underlying philosophical beliefs are
Right.
on the role of health insurance in society.
Right.
Is it a public good, or is it not? I
Mhm.
mean, do we believe health insurance is a right?
Right.
And that cost should not be the barrier to people getting access to health care. We really have not had that explicit discussion.
Right.
You can see a lot of implicit beliefs in some of the things that have been proposed, but I will tell you that particularly the opponents of the Affordable Care Act and those who want to repeal it, they say one thing, but
Mhm.
they act in a different way in terms of what their beliefs are, because the idea that it's purely a market good is not a very popular
Right.
idea.
Right.
People want protection from the cost of healthcare.
Mhm.
People, I think most people, from a consumer standpoint, say we should have health insurance, and it should be paid for in some way beyond out of our individual pockets.
Right, right. And sort of throughout this podcast, a broad theme that has come up is the disconnect that can arise from sort of national level policy funneling down to like individual practitioners sort of on the ground implementing that policy. So I wonder if you could just speak briefly from, putting your CHRT hat on and looking at what the passage of the Affordable Care Act or sort of healthcare more broadly has done to impact the work that you do in Michigan.
Yeah, so the work that we do in Michigan is very much about expanding access to care and improving population health. And we do believe pretty strongly that insurance is necessary to improve both population health and access to care. Now, that's been debated. I mean, there are people who say, well, there's not an association between insurance and health status. And there have been some studies out in Oregon and others that have led some people to think that. But we actually have, I think, more data to say health insurance is necessary to improve population health. It's not sufficient.
Yeah.
There are a lot of other things that need to be dealt with, but it is necessary. And so we do believe that it is an important element. We spend a lot of time working with state legislators and the public at large to try to explain the Affordable Care Act and what it is and what it is not, why we think it is an important element. It is by no means a perfect law. There are many issues with it, but we do believe that it is better than what we had in place before.
Right.
And so we spend a lot of time trying to help sort of fact from fiction and to really communicate what this is really all about and what the alternatives are and what they would look like and what their impacts would be.
Yeah.
Right.
So speaking of alternatives, or even just better understanding what could have been part of the Affordable Care Act, I know that Barack Obama pushed a lot to get a public option.
Yes.
So can you help us understand what that is and how healthcare might be different if that was included?
Yeah. So the public option was extremely controversial at the time it was being proposed, and it wouldn't have made it through Congress at that point. But the idea was that, and it's really relevant right now, in areas where people would have difficulty getting coverage or where the cost was very high, people should have the option to buy into a public program like Medicare or buy into a public program like Medicaid. Now, some people talk about it in terms of making access to the federal employees health benefit program available to people in communities where there are not a lot of choices of health plans. And the idea is, well, as I told you, Medicaid pays less to providers than private health insurance, and so to cover an individual in Medicaid is lower cost than with private coverage. And so it probably would have enabled people to get broader coverage at a lower price than they're getting from the private market. It was controversial in part. The health plans at the time this was being debated didn't like the idea because it would reduce their market share, right? It would go into more, and some people saw it as a backdoor into single payer, that over time health plans would not be able to compete with government programs, and we would move more and more of the population. As I told you, almost 40% of the countries now in public programs, we would move more into those public programs.
Right.
And so it was not supported at the time. It came back in discussions around the presidential election, and I think if Hillary Clinton had been elected, we would be very much back to talking about the public option as a way to deal with some of the regions in the country that have very few choices of health plans in the marketplace.
Right. So the public option provides people with an alternative to like the private market.
That's right.
Got it.
Yeah.
Mm-hmm. So I think our final question is just sort of, there are, healthcare is clearly very top of mind for many people, and I think the debates are strong, and there's, I think, reason to separate fact from fiction a lot of the times. What is it that, you would want our listeners to take away, or like what's an important thing that might not be talked about or is talked about but isn't emphasized enough when we debate healthcare in the U.S.?
I have one or two more questions after that too.
Yeah, so I think this underlying belief system is not talked about enough when we talk about healthcare. What are your goals? Quite honestly, there really aren't a lot of, if you believe we should have universal healthcare financed in this country, there aren't a lot of ways to get there.
Mm-hmm.
And I think there are a lot of myths about how you can get there. The latest one, this is just incredible to me, is this idea we're about to come out with a rule that President Trump is going to announce, I believe, this week, at least he said he is, on association health plans.
Okay.
And there is things that are too good to be true are too good to be true.
What are they? Association health plans?
So he's going to come out with a rule this week that will enable people. He says, he tweets, we're going to make fast healthcare coverage better and cheaper for everybody. Right. So, and we're going to do it through what's known as these association health plans. And these association health plans are basically the idea behind them is to say, we could form a group, the three of us could form a group, and we could say we're an association of University of Michigan fans.
Mm-hmm.
That's us. And we're going to provide health insurance, and we're going to call ourselves a group, and we're going to call ourselves an employer and a big group. And so we're not going to have to abide by any of the provisions of the Affordable Care Act. And we're going to have really cheap coverage because we're going to have skinny benefits, and we're only going to let healthy people in. That's the idea behind an association. Anybody can form a group. We're not going to be subject to state regulation.
And that group can exclude anyone from entering as well.
Exclude anybody. It violates all the rules of the Affordable Care Act, right? So we'll have cheaper coverage because we're only going to cover people who don't need coverage, right? And so, there are just so many myths out there. You don't get something for nothing. You have to understand the principles of health insurance and how it works and why is healthcare so expensive. We need to be talking. None of the proposals to repeal and replace the Affordable Care Act dealt with the core issue that you asked about. Why is healthcare so expensive, and how do we actually deal with the cost in this country? Why does every other country spend less on healthcare and get better outcomes than we do? We haven't dealt with that core issue. And so that's what I think people need to understand. There is no magic to design a repeal and replace, and all the things that have been said about we're going to provide better coverage cheaper for everybody is false.
Mm-hmm.
It's just patently false. Providing lower cost coverage in the current system means some people will pay much more or not get coverage at all.
Right. And I have a couple more. We'll do some editing around to make sure that we could close with that one. But I'd love to better understand. So single payer has been like a really big part of the conversation recently. It's something that Bernie Sanders is pushing, and I don't think it's very well understood. And I'd love to understand from you what are the merits, what are the drawbacks, what is the plausibility. Maybe we could start with what is it.
You're going to have to take my class. These are long questions.
Yes.
These are complicated questions. Okay, what is single payer? So single payer, first of all, is the idea that there is a single entity, a public entity, that is providing financing for healthcare for people in a defined area, right? Not all programs in Europe or Japan are single-payer systems. We have some that are multi-payer systems, but they are still government funded. There is the idea in Canada that by province there is a single-payer governmental program in that province, right? Canada, by the way, is not a national program, has national principles, but each province is slightly different, right? So it's the idea, and generally those are funded by tax, through tax systems, right? And so, and you know, that is what Medicare is. So Bernie's proposal is really Medicare for all, really. It's an expansion of the Medicare program, which has been very successful. Medicare has some big limits to it, however, which we could talk about, but Medicare generally is popular, has been successful, is lower cost than the private market, and that is what his proposal is, to expand Medicare. There are a lot of good features to single payers. They're much simpler. They don't, you know, we now have in this country thousands of health insurers, millions of health plans, as I said earlier. This creates a lot of administrative costs that does not add value from a population health standpoint. Right, so single payer cuts out a lot of that stuff. It's much simpler. It is much more focused on just delivering care.
Would administrative costs go down in a single
Administrative costs would go down enormously because you're not dealing with multiple different payers and the complexity of multiple different health plans.
That sounds nice.
Right, it's fantastic. Yeah, and it's much clearer. Right, so operationally, and if you go across the border and you go to Canada and you ask people in Canada, would you want the American system or the Canadian system? They'll tell you. The Canadian system has some issues, but are you kidding? Would I want an American system of healthcare? No way. The Canadian system's much better from their standpoint, even though it has problems, and they would change a lot of things about it, right? So it's a great system. I think if you were, you know, drawing out a system independent of political and cultural history, that's probably a great approach to go. It has a lot of political risks in this country, and I think it's unlikely to pass in this country. Even though I think people say they like it, but they don't really understand the details of it. You have to be a country that's willing to pay a lot more in taxes than Americans have historically. A lot more.
It is so, but even if Americans are paying more in taxes, wouldn't they would no longer be paying like the $10,000 or so a year that they average pay for healthcare, right? Like, is it possible that like net on the balance sheet, Americans?
So the problem is, again, if you go back to the fact that we have a fragmented healthcare financing system in this country, and so many people get their coverage through their employer, and even though co-pays have been going up and deductibles have been going up more in the $1,000 to $5,000 range on an annual basis, most people don't recognize that they are effectively paying for health insurance through their employer by reduced wages.
Yes.
And so they'd actually have to see a big wage increase. You know, economists understand this issue, that, you know, it's really the employees that are paying, not the employer per se, but employees don't really see that. So what they would, unfortunately, I think what most people would see is, oh, I have this big increase in taxes, and maybe I got a bump in my wages, but it's not going to offset the increase in taxes in their view. Now, there are a lot of hidden costs in health insurance, and health insurance right now, because of the way our tax system works, is tax preferred, and so consumers don't see the total cost of health care. And so yes, net, is it cheaper? Is a single payer system cheaper for a variety of reasons? There are other features to it that are important, not just the way it's financed, but yes, it's going to be cheaper, but many consumers wouldn't actually perceive it that way. They would just perceive it as a tax increase.
Fascinating. Do you want to close with an ideal?
Yeah. So say you were in the room in the Obama administration, working out the framework of the Affordable Care Act, and we're in a political vacuum. And I think you've touched on many of these elements, but sort of, what are those features of a healthcare system that you'd want in an ideal world?
Yeah. So if you were given like a blank check on political capital, how would you craft an ideal system? Yeah.
So if you look at the systems that have been crafted around the world, I think their starting point is with the systems that work the best. And I think that we're pretty clear on the systems that work the best if you're measuring it based upon the cost of care and population health as the two factors that you would most want to achieve. And we have two systems that perform extremely well in those measures. The British system, which is the closest to actual socialized medicine, where many of the employees are employees of the state, effectively, which is a national health service, and a style like a Canadian system, which is a national health plan, health insurance, single payer. Those are both systems that we have great data to show they really work well. They both have issues. In both of them, they're underinvesting. The big thing that I think if you really had a blank slate, and if you gave me the pen to design it, that I would do is I would go down either one of those systems for health insurance, but what I would do is invest far more than we do in the core social determinants of health that are driving healthcare spending at its base.
Okay.
Right? So the core things that we know increase healthcare costs are frankly the things that are most important from an economic standpoint. So income disparities, poverty-related issues, mental health-related issues, all of those kinds of things. If we could do more for education, for early childhood education, for basic education for people so they became more employable, if we can fund more for mental health services, those kinds of things would both reduce income inequality and actually over time reduce healthcare spending. Every European country invests more in those basic human services than we do in this country, much more. And if you add their spending on human services and they're adding on healthcare, it's not that different from the U.S. It's just that we spend far more on medical care and far less on human services. I would shift that balance to look much more like they do and invest in our human capital from the earliest ages, and design a system that was either single payer or a national health system that had reduced administrative cost, much less complexity.
Right. And so that investing in human capital would involve a lot of investment in preventative care too? Is that part of it?
Yeah, but primary preventive care. Preventive care is not going to the doctor and getting a well health exam. That's expensive care. Or not expensive care, but it doesn't save money, right? I'm really talking about primary care, like seatbelts, helmets for motorcycles. Those kinds of things are preventive care because they avoid outcomes down the road completely. They don't just deal with your illness once you get it. That kind of preventive care is what I'm talking about. So you asked me the question of what would be my ideal state if I had a blank sheet that was political, neutral. In the political environment, however, I have a different answer to that question. And the answer is, I actually think you could, if you were doing a completely blank slate currently without all the rhetoric that's been out there, I do think you could do a national catastrophic program that was single payer. I think there is actual support that people should not have to go bankrupt if they got serious medical illness.
Okay.
I think you could get a public program around that idea. And we could spend more time talking about that. But I think that's another alternative path that you could get to in this country that might advance care for people as well.
Wonderful. Well, I think these conversations will absolutely continue to keep happening. Marianne, I just want to thank you so much for the thoughtful and engaging conversation.
Yeah, happy to do it.
Wow, what a great interview with Marianne. So informative, engaging, and really we just wanted to take a moment and step back and chat a bit about our main takeaways.
Yeah, so what did you take away from that, Matt?
First and foremost, this idea that what was so foundational about the Affordable Care Act is the expansion of insurance coverage to low-income people particularly through the expansion of Medicaid.
Definitely. Yeah, one of the things that was most fascinating to me about how she was presenting that data was that Medicaid it covers less than the hospital's costs or expenses or whatever that is. That was really interesting to me.
Certainly, and I think really what your questions brought to light is very much this cost aspect of the health insurance system in general and also the implications for the Affordable Care Act. So I wonder if you, what did you take away from those those conversations that Marianne provided?
Yeah, I mean, I think that I'm still just struggling to understand coming out of reporting like Stephen Brill's. So Stephen Brill is a journalist who had a Times cover article or a cover article in a Time magazine. I believe it was either 2013 or 14, and it was called The Bitter Pill, and it was about just wildly high expenses in the industry. And the example on the cover was, I believe, a hospital charging $55 for one, either acetaminophen or ibuprofen. And you know, we all know that we can get a bottle for $100 on Amazon for, you know, like considerably less than that. Let's just say like 1/10 the price, but I think it'd be closer to like 1/100 the price. And so understanding that, you know, you don't find those markups like, you know, 10,000% in any other industry, you know, outside of like narco trafficking, is really, I don't know, it's like understanding the hospital's economics was really important to me. And I felt that, you know, the way she was framing a hospital's economics is, you know, having relatively thin 2 to 3% profit margins. Like I really wanted to continue to ask her about like where do those expenses come from? And I think she answered some of that by talking about how hospitals don't allocate on a per item basis, so they probably don't know how much they charge for like an ibuprofen.
Very much. And I think all of those conversations sort of come from this basic and foundational belief in the U.S. that healthcare should be treated as a market good and not necessarily as a right or a social good. And I think when those conversations...
But the public consensus is that it should be treated as like a social good, right?
Very much. But every act and every problem that arises due to the fact that it's treated as a market good. So it's this disconnect between believing one thing, believing that this should be a right, this should be a social good, yet it's rationed and treated in such a way that it's something that's transacted within the market. And that's when these issues really come to light and become a problem.
Yeah, definitely. And I think that framing is sort of absent from the discussion. I think that, honestly, opponents of the Affordable Care Act do a really good job sort of divorcing that conversation from the ethics of treating it like a market good, when in reality, treating it like a market good causes things like 62% of Americans bankruptcies being a result of medical bills.
Yeah.
So another stat that I found really interesting was that, so understanding the proportion of the population that's actually on these, you know, Obamacare exchanges, right? Like, I think, so she said that number was
5%.
5%, right?
5% of the U.S. population that is of adult age are within this bracket that has to cover themselves through insurance, through purchasing it on the exchange, which really, you know, shines light on this broader point of access to care increasing under the Affordable Care Act. Because it's not as though the unemployment rate has changed drastically in recent years. It's not as though people are receiving more insurance from employers. It's this expansion of social insurance systems such as Medicare, as well as these sort of broader means-tested programs such as Medicaid.
Yeah, and so speaking of Medicare and Medicaid, another really fascinating statistic was the percentage of Michiganders that she said were covered by one of these government programs. So from what I remember, it was 25% about on Medicaid and 15% on Medicare. And I think it's those numbers really put into context how many people will be impacted by the repeal of the Affordable Care Act, because those 25% of Michiganders, you know, their Medicaid is going to be woefully underfunded if the Affordable Care Act is repealed. I mean, that was definitely another takeaway of mine from the conversation. And how those people are going to have their needs met is sort of an open discussion that I think we're left to sort of find answers from you know, opponents of the Affordable Care Act.
Very much. And we touched on this a bit in our interview, but looking forward in the current administration, and this, I think, at the time of recording is a hot take, but I think once we release will be a lukewarm, if not cold take, but the Trump administration has sort of come out with this executive order that, in very general terms, sort of takes what Marianne described as an association health plan and allows the expansion of that to essentially create a system that allows groups of people, whether they be small businesses or other associations, and create a system in which premiums are much lower and health coverage is much lower.
Right.
And you can exclude people based on their health status.
Yeah, and that exclusionary element is, I think, one of the most important pieces, because those kind of solutions are presented as solutions to the very high cost of healthcare. But it's these most vulnerable populations that we don't really address clear, alternatives for. And one of those alternatives includes like these high risk pools, right? And the data that I've seen on these high risk pools is that they're going to be chronically underfunded, as Dr. Phillips described. So how these most vulnerable populations are going to fare in a Affordable Care Act free system is definitely a concern.
Certainly, yeah, and I think it's all based on this fact that insurance is designed to cushion the blow of people with very high healthcare costs,
right?
So that everyone pays into the system, and you then do not internalize the full cost of your healthcare. But the only way to do that is to mandate people to pay into a system, which, again, as Marianne mentioned, as I think we all are aware, is in some ways an anti-American way of going about policy, that there's some amount of aversion to being told what to do, to being mandated what to do, yet the system cannot exist without having some amount of requirement to have young, healthy people pay into a system that in some way subsidizes poor, sick, and old people.
Yeah, and I think so one way I do kind of want to push back on that is, one thing we are very much mandated to pay for in the United States is our taxes, right? And so in a single payer system, and we'll talk more about solutions in the next episode. In a single payer system, we're still required to pay for healthcare. The government does it on our behalf, and because of that, because they're a single payer, they get much lower costs and stuff. But generally speaking, like, it's whether or not we're being mandated to pay, like, to buy individual healthcare insurance, or whether or not we're mandated to just spend a little bit more inside of our taxes. It feels kind of like tomato to me there, and we're gonna tease out that conversation more in our solutions episode.
Certainly, yeah. I think the only point that I was trying to make is the idea that a mandate is very much against the mentality of Americans, as are taxes. Like, America is very tax averse for the exact same reasons, that we don't like to be told what to do. And I think any solution, as Sean mentioned, any solution as we talk about this in future episodes and in part 2, has to be premised along that line, that there's going to be a lot of pushback, particularly political pushback, for anything that sort of goes against this independence that America is based on and premised in.